C3 Collaborating for Health. We'll just wait a minute or two for people are still joining us, but you're all very welcome. You haven't got time to go and make another cup of coffee. We'll start very shortly. So I know we've got people from many places, but here in central London, sun is shining, the sky's blue, so everything's set for a good morning, and looking forward to you all joining us. It's just coming up to 8:30 and we'll start in a few minutes. And please put yourselves on mute, other than the speakers. We do want to hear them very shortly. Hello, good morning, good afternoon, good evening. I'm Christine Hancock, welcoming you to C3 Collaborating for Health's international seminar today. Delighted to see many people joining from many parts of the world, and I can see some people are still joining, so I'll talk a bit slowly to give people time to join us, and you're very welcome. So C3 Collaborating for Health is a small charity NGO headquartered in London, working globally and focused on preventing chronic disease, really by looking very much at the main risk factors, what we eat and drink, lack of physical activity, and smoking as the drivers of so much ill health. Our seminars, which we began from our earliest days, and I think we're 14 years old now. So from our earliest days, we felt that the opportunity for people to hear speakers from other countries and to learn of successes and indeed challenges that would resonate initially with the UK audience, because we started them with real food at real breakfast time when people met together. Do you remember those days? And talked and shared business cards and had coffee together, and we made wonderful, healthy breakfasts. Clearly those days have changed. And the push to go online by the pandemic has given us all sorts of opportunities. We no longer have to capture somebody coming through London for other reasons to give one of our seminars. By being online, we can obviously engage with people from much wider audience, both within the UK and much wider. And we've managed to run at different time zones. But today we're back to London-based breakfast time, although our speaker comes from the other end of the time zones, but Bruce Neal is in England, in London today. So we could almost have had a physical session, except that several of the people who are joining wouldn't have been able to join it. So really delighted to welcome Bruce for the second time he's given one of our international seminars. And I think he was speaker number 2 or 3 in our very earliest days. So I think he'll tell us both good and bad news about what things have changed over that decade or more since he last spoke. And Bruce is bringing a global perspective to a real problem. If people haven't seen today's Guardian, runs a big story on the amount of salt in a pizza to last you for the whole day, and differences between the different popular makes of pizza. So with no more from me, but please look at our chat, put your questions on the chat. And think about, if you're not already, join the C3 network so you can hear about our seminars and other activities that we're involved in. But Bruce, we're really delighted that you're here and able to bring us up to date on one of the, I think, too little talked about of the dietary challenges most of the world is currently facing. So over to you.
Thanks very much, Christine. It's a pleasure to be here. Claudia, if you could share the first slide, that would be great, please. Thank you. So what I'm going to do is talk about why can't we cut the salt, and it is slightly difficult, maybe slightly embarrassing to be back here 15 years later and declare that really we've made very little progress on a global perspective in regard to cutting the salt. But at the same time, as I hope will become clear as I go through the presentation, there is hope. And I plan to leave with aspiration and ambition at the end of the presentation. So next slide, please. So just a quick bit of background to start with. I think you're probably all aware that if you eat too much dietary sodium, and sodium comes mostly from salt, sodium chloride, then that is associated with higher blood pressure, and higher blood pressure is still, I think, the biggest individual risk factor for premature death and disability in the world, because it causes cardiovascular diseases, and cardiovascular diseases are the leading cause of death and one of the leading causes of disease burden. So most people in the world eat far more sodium than they need. During hominid evolution, man evolved on a diet which probably had less than half a gram of sodium a day in a Paleolithic diet. Now, by contrast, average consumption in the world is about 4 grams of sodium a day. To turn that into salt, you multiply sodium by about 2.5. So it's about 10 grams of salt is sort of global average. So we're not just eating a little bit more sodium than we evolved on, but we're eating about 5 to 10 times more. Now, that's a real problem because that excess sodium consumption causes millions of strokes, heart attacks, and premature deaths each year. But there's also a silver lining to that cloud, because what it also means is that most people in the world have the potential for reducing that cardiovascular risk by reducing their sodium intake to lower their blood pressure. Have the next slide, please, Claudia. So I talked a lot about this challenge and what we might do about it 15 years ago when I last had the opportunity to speak at the C3 seminar series. And there's just recently been a really comprehensive, very high quality review of progress on sodium reduction all around the world, led by the World Health Organization. And what they identified was that about 10 years ago, 194 member states of the United Nations committed to try and achieve a 30% reduction in sodium intake by 2025. The WHO spent a lot of time developing materials, promoting those materials to member states. In terms of what's actually happened, it's a somewhat sorry story. About 5% of member states, so that's single figure member states, have implemented all of the sodium related best buy interventions. About a fifth have implemented one mandatory intervention, about a third at least one voluntary measure, and about, again, a third have implemented a policy commitment. What is a bit more depressing, those numbers are not great in their own right, but evidence that these have actually delivered sodium reduction at a population level is really, really sparse. And that's partly because we don't have good surveys to actually detect whether there have been effects, but probably also most of the things that have been implemented have been somewhat weak, and even if they have been proposed, have not been implemented fully effectively. The bottom line is that none of the United Nations member states are anticipated to achieve that 30% reduction target by 2025, and most will have most likely achieved no reduction in average intake by 2025. So next slide, please. So why is this so difficult? And it's actually sort of pretty obvious when you look at it, which is that all of the things that the shake package, the WHO package of sodium reduction strategies require are pretty hard to do. Now, broadly, you get salt or sodium from a couple of places in the diet. So you either add it when you're seasoning or cooking food at the home, or if you're living in a more developed country where you eat a lot of processed and packaged foods, then the majority of it will be provided to you by industry, who add a fair bit of salt to products when they are when they're prepared. Now, if you're a consumer, it's actually very hard to get you to change how much salt you put in when you cook and when you season, and to get used to a less salty taste. If you can do it, I'd recommend it. I've done it. You taste a whole bunch of other things than salt in your food. It's tremendous, but it is a very difficult thing to do. Likewise, if you're industry, you have to change recipes, you have to do taste testing related to changing those recipes, you have to update the packaging, and ultimately you have to risk market share if your competitors who sell similar products are not doing the same thing. And finally, if your government, who you think would have a significant vested interest in driving this sort of change, you need to design policy, you need to implement regulation, and you need to then enforce that. And the challenge for government is that they're mostly under-resourced, they're mostly looking for a quiet life. And if you want to implement this sort of intervention, then basically what you're going to do is come up against the food industry. And that's not something that most governments around the world have proved willing to do. So next slide, please. Just before I get on to the solution to this problem, I just want to talk briefly about another very important dietary component, potassium. So potassium is one of the main reasons why fresh fruits and vegetables are very good for you. And if you don't eat enough dietary potassium, then you also get higher blood pressure levels and higher cardiovascular risks. Most people in the world eat potassium far below the optimum. Again, if we go back to the Paleolithic diet, that diet typically included about 10 grams of potassium each day. And nowadays, average global consumption is a bit under 3, so about a quarter of what it's intended to be. Once again, this causes millions of strokes, heart attacks, premature deaths each year because it's associated with higher blood pressure. But once again, there is a silver lining in that cloud, in that if we could get people to eat more potassium, then very large numbers of events could potentially be averted. Efforts to get people to eat more potassium are mostly focused on sort of dietary guidelines, trying to get people to eat more fresh fruits and vegetables. And once again, progress achieving that has been almost universally disappointing globally, because once again, you're coming up against major commercial interests which are driving increased consumption of packaged and processed foods all around the world. Next slide, please. So we got really interested about 10, 15 years ago in what we call salt substitutes or potassium-enriched salts. And there are a couple of reasons we're interested in these. The first is that they combine a solution to the joint challenges of having too much sodium and insufficient potassium. And they're also feasible for use by consumers and industry in a way that's simply trying to get people to not add as much sodium or to eat more fresh fruits and vegetables hasn't proved to be. We've had a lot of evidence for a long time that potassium-enriched salts can reduce blood pressure from about 20 or so randomized trials. But until recently, we hadn't got that sort of really definitive evidence that these products could reduce the risk of cardiovascular events, and also that they were safe to use. And I'll come back to the safety piece in a minute because it's important. Next slide, please. So just going to talk briefly about a large study we completed about 18 months ago now, called the Salt Substitute and Stroke Study. So this was a very pragmatic, large-scale trial that we did in China. And the goal, I come from a background of doing a lot of studies of drug therapies. And when we study drug therapies, we are required by the regulators to do trials that are sufficiently large to show whether they actually protect you against strokes, heart attacks, dying prematurely, not just whether they change your blood pressure level and the like. And so we wanted to do the same thing for potassium enriched salt. So we put just under 21,000 people into an open trial. So people knew whether they were getting the salt or the salt substitute. And we also cluster randomized it. I won't go into the detail of that now, but what that meant was that rather than randomly assigning each individual to salt or salt substitute, we randomly assigned 600 villages with about 30 people in each village to get salt or salt substitute. The end result is sort of the same, but practically it was much easier for us to implement the project in that way. So as I inferred, we recruited 21,000 people in these 600 villages. Once we'd completed recruitment of individuals, we randomly assigned the villages to either get a free supply of potassium enriched salt for the 35 villages in each of those villages, or for them to just continue using regular salt in the usual way that they did. And the salt substitute that we used, instead of being 100% sodium chloride like the regular salt, was 25% potassium chloride, but still 75% sodium chloride. So potassium enrichment at a 25% rate. Next slide, please. So we put participants in the study. We followed them for just under 5 years on average. We were able to link to various routinely collected data sources, which meant we were able to get very complete follow-up for all of our participants. And one of the most notable things was that at 5 years, 92% of the people who we assigned to use the salt substitute were still using the salt substitute. And again, if I reflect back to drug trials, if we had 50 or 60% of people still using the drug 3 or 4 years into the study, we'd feel like we were doing pretty well. So it really highlights that this is a very well tolerated, acceptable intervention to community. The next slide, please. I'll just run through the main results now. So the primary thing we were looking at was the effect on stroke. We recorded about 3,000 strokes during the study, and you can see there the lines sort of separate pretty early. The lower line is the salt substitute, the potassium enriched salt line, and the dark top line is the regular salt line. What that means is that there was a 14% lower risk of you having a stroke if you use the potassium enriched salt, and the p-value of 0.006 basically tells us that it was a pretty compelling finding. The next slide, we had 2 secondary outcomes that we pre-specified. The first was major adverse cardiovascular events, which is really strokes plus heart attacks plus any other deaths from cardiovascular disease. We recorded about 5,000 of those events during the study. The participants, I should say, were older people who were at risk of cardiovascular disease. We got a 13% reduction in the risk of having a stroke or a heart attack, and again with a very small p-value, meaning it's a very compelling result. And then the other secondary outcome, next slide please, Claudia, was total mortality. And this is really the outcome that you really want to have an impact on. About 4,000 people died in the study over the 5-year period, and there was a 12% reduction in the risk of premature death if you used the potassium enriched salt, and again with a very compelling p-value. So in terms of looking for the benefits, we really got everything that we wanted, and in fact the sizes of the effects were almost exactly what we expected. The other key outcome for the study was hyperkalemia, and this was the safety outcome. So hyperkalemia is a condition of high blood potassium levels. High blood potassium levels are dangerous if they get too high, because they can increase your risk of getting heart arrhythmias and indeed dying from those heart arrhythmias. So the first thing you can see here is that the lines are very low down on the axes. So there were only 300 of these events that occurred, and you can see the rate ratio is 1.04, very close to unity, with a confidence interval that goes a long way either side of that, and a p-value of 0.76. And what this means is that we saw no evidence that there was an increased risk of hyperkalemia. So I'm just checking. So someone said they couldn't hear me, but everyone else can hear me okay? Yeah, Christine's nodding, sorry. In that case, next slide, I'll just push on. So this balance of benefits and risks is really important because it is something that if you go to medical school, as I did, it's something that you learn about early and you're very concerned about. But it is a problem that is restricted to people with severe kidney disease. So the kidney is the primary organ for managing potassium levels in the blood. If you get really serious kidney disease, then you are at higher risk of getting high blood potassium levels and serious complications or even dying from it. However, serious kidney disease is uncommon. It's less than 1% of the population, and it's probably more like 0.2, 0.3% of the population that have serious kidney disease. When kidney disease is that severe, it's almost always diagnosed unless you're living in a very resource poor setting. And if you have kidney disease of that severity, you are told in no uncertain terms that one, you shouldn't be eating salt because blood pressure problems are big for people with kidney disease. And you were also told that you should not eat any potassium supplements and particular foods are to be avoided. So there's no doubt that it is a risk. If you have that condition and you eat potassium-enriched salt, you would likely increase your risk of hyperkalemia, but it's also a risk that should be highly manageable in most settings. And in the SAS trial that I just spoke about, we tested this fairly robustly because the people we put in the study were mostly older people with cardiovascular disease who are at high risk for having kidney disease. We used very pragmatic inclusion and exclusion criteria for that study. We didn't test kidney function with blood tests in a formal way for that study. We simply said, if you've got serious kidney disease, you and your family can't join the study. And we also had about a quarter of the people in that study using drugs that raise blood potassium because they're routinely used to protect against high blood pressure and against complications. So again, the fact that we saw no adverse effect on hyperkalemia in the SAS study is very reassuring in terms of widespread use of potassium-enriched salt. So we concluded from that study large potential gains from population-wide use. And it's of note that potassium-enriched salts are already widely available. They're available in about 30 or 40 countries around the world, but just not widely used. Next slide, please. So the reason we're so interested in potassium-enriched salt does come back to the potential health impact. And we did a modeling study for China using data directly comparable to the results we got from the SAS study. And basically in China, there's about 10 million strokes and heart attacks and cardiovascular deaths that occur each year in the population of about 1.2 billion. If you were to switch the entire salt supply in China from regular salt to potassium-enriched salt, you would prevent about 10% of those, so just under 1 million strokes and heart attacks each year. And that, I mean, I work in lots of different areas. That's a pretty enormous potential impact. Done similar work for India recently, and again, you get similarly huge potential for prevention. Next slide, please. So we're now interested in the idea of trying to switch the world's salt supply from regular salt to potassium-enriched salt because of that potential to prevent many millions of strokes and heart attacks each year. The reason that we're so interested in the potassium-enriched salt is that unlike other sodium reduction strategies, and indeed unlike other potassium raising strategies, we think it is feasible and plausible and scalable in a way that the others aren't. And the other part of this that's really important is that it's a pretty low cost product. Now, potassium enriched salt is more expensive than regular salt, and it's often sold at a price premium as a health product, but you can produce it for about 30 to 50% more than regular salt. Now, that's obviously a significant markup on regular salt, but regular salt, you have to remember, is a very low cost product in most countries around the world. The other thing to say is that the world's salt supply has already been changed once from salt to iodized salt to prevent iodine deficiency disorders in children and pregnant women. And that is widely hailed as a huge global health success. It does leave us with a little bit of a problem, though, because what you're doing with the iodization program is adding iodine, which is good, to salt, which is bad. And if we were to able to switch from iodized salt to iodized and potassium enriched salt, then you'd actually have a product that was doing good things, both preventing iodine deficiency disorder and preventing chronic non-communicable diseases of cardiovascular diseases. And the other piece here is that because it has been achieved once, it feels like making a second switch to the world's salt supply should be a tractable proposition. We're coming to the last slide now. There's obviously lots of challenges that we're going to face along the way. So lots of people don't know about potassium enriched salt. We have to raise visibility. Understanding of the balance of benefits and risks is a real challenge. I see sort of real parallels here around the sort of discussions that were had around vaccination for COVID, where you've got this incredibly infrequent risk trading off against massive potential benefit, and the inability of, even clinicians in some cases to be able to balance this in an effective way. The World Health Organization recently has launched some draft guidelines on use of potassium enriched salt, and I'm disappointed to say that the World Health Organization has really failed in those draft guidelines to properly get across the likely balance of risks and benefits, and that's something that is obviously going to be very important for us to discuss with the World Health Organization. Challenges in terms of manufacture, distribution, retail. At the moment, the world consumes up 20 to 25 million tons of human grade salt at the moment. If we wanted to replace a quarter of that with potassium, we'd need 5 to 10 million, 5 or 7 million tons of potassium chloride. Probably at the moment, there's only a few 100,000 tons of food grade potassium chloride produced worldwide. We would need consumers to change. We would need industry to adopt. I think one of the positives for industry is that salt makes up a very small proportion of most products, and a slightly more expensive potassium enriched salt would be a minimal impact in terms of cost of products. The technical feasibility would, I think, be good for most product ranges, although there would be some product ranges where it would be more challenging. Price will undoubtedly be a challenge. When you're in a high income country, probably less so, but as soon as you get down to a low or a middle income setting, even though salt is a very low cost product, a 30% price premium will be noticed and does have an impact. I think I saw a chat message come up about taste. Taste, I've put in brackets there because it's widely perceived that taste will be different, but it does seem that if you use a 25%, 75% potassium chloride, sodium chloride mix, the taste difference is undetectable for most people. It will be detectable for some. Most people will deal with that, particularly if they think they're getting a blood pressure benefit out of it. So I haven't really addressed all the key challenges, just sort of skimmed over them, but they might be something that we want to cover in the discussion. I'll finish here, Christine, and hand over to Mhairi.
Bruce, thank you. Fascinating, and I'm sure there will be lots of questions. I've got several already brewing that I'll save for the moment. And moving from your presentation to hear from Mhairi the UK perspective, because I think you said to me on a call when we were organising this how to some extent the UK had been a leader and now was not quite such a strong position. So thank you for starting it. Thank you, Claudia, for managing the slides, and both of you from the George Institute with whom we're collaborating for this series of international seminars. And to make sure you know about all our international seminars, make sure you join our network. Links on the chat. But Mhairi, over to you to bring an audience which isn't entirely UK, but quite a lot of people from the UK, up to date with what's happening here and what should be happening here. And then we'll widen the meeting to encourage questions. So please put questions in the chat. But first of all, Mhairi, please introduce yourself and fill us in on what's happening in the country where we're speaking from.
Lovely. Thank you so much, Christine, and good morning, everyone. It's such a pleasure to be speaking to you today, especially during Salt Awareness Week. Our theme for the week this year is to ditch the salt. And that message has gone to the government, the food industry and the public, and reduced sodium salts are absolutely a key part of that. So I'm going to discuss the barriers and opportunities to increasing the use of these reduced sodium substitutes in the UK. But first, I thought it would be a good idea to start with a quick overview of more general progress with salt reduction, which has seen its fair share of barriers and not too many opportunities lately. So initiatives to try to reduce how much salt we eat as a nation have been around for a couple of decades in the UK, and it all began with setting novel salt reduction targets across 80 categories of food to try to encourage the food industry to add less salt to their products. There was also a public awareness campaign which was designed to help adults and children just understand that they should be eating less salt, and that really supported the implementation of the policy and the maintenance for a couple of years as well. And at the same time, we were starting to see front of pack labeling coming in, so the food industry were being a lot more clear with their consumers how much salt they were adding into their food, and that's now present across many products. But the targets were really the driving force. As a result of those targets, initially, salt levels fell in many products between 20 to 40%. And alongside that, we saw reductions in our population salt intake, our average blood pressure, and deaths from cardiovascular disease. But in recent years, progress has stalled. Salt intake has not fallen in the population for many years. The last time it was measured back in 2018, it had actually increased, a non-significant increase, but it's definitely not going down. And the salt targets that were due to be met by 2017 were not fully met. The government then released a new set of targets, which are due to be met next year, but who is to say that they would be met if the previous set were not met? And the issues that have led to this stall in progress are numerous. This is actually the focus of my PhD, to evaluate salt and sugar reduction programs in the UK and identify what's really gone wrong. It's complex and there's lots of rich data, but there are some areas that we can start to highlight. And the governance of the program, so the oversight has transferred several times from the Food Standards Agency, who launched this program. They were able to drive forward progress, but then responsibility transferred to the Department of Health and their public health responsibility deal. We could have a whole session on the responsibility deal alone. It was a real failure because it put the responsibility for salt reduction and the responsibility for policing progress into the hands of the food industry. After the 2015 general election, the responsibility deal was dissolved and we were in limbo. It wasn't until 2017 that Public Health England actually took oversight of salt reduction. They were able to release some quite comprehensive monitoring reports. It was the first time we'd really seen that level of data for salt reduction, which was really positive. But then Public Health England were dissolved in 2021, and now responsibility is back with the government. And I think it's really important to think through that, because there's been such a frequent change in governance of the programme. There have been differing ways of doing this, and we haven't learned what's worked and then just driven forward with that. It's really not hard to see how progress has stalled. Momentum has just been completely lost. There's another layer to this as well, which is leadership from government. Alongside the various bodies that have taken ownership of salt reduction, there have been numerous health ministers in post, and all of them have their own ambitions and directions that they want to take health policy in. General elections or cabinet reshuffles can bring a new health minister, And then there was 2022. I was trying to think of an appropriate collective noun, like, a conspiracy of lemurs, for just how many health ministers we had last year. But needless to say, there was quite a few. And every minister that comes in has to be briefed. They have to be given the evidence, and they all want to make a difference. They all see that the NHS is on fire and they try to tackle it. And over time, they start to see that prevention is really key. If we don't invest in prevention, we're not going to do anything about the NHS being on fire. But as soon as that message takes hold, usually a new health minister will come into place. And of course, I should mention as well that COVID really did a number on all of us. And while we did see much more recognition that obesity was a key risk factor, that kind of commitment to addressing cardiovascular disease in the UK just seems to be missing. So how does all of this translate into reduced sodium salts? All of these barriers for general salt reduction can't be ignored. We have a government that is not prioritising salt reduction. The use of reduced sodium salts could be one way that they start to move forward and have an impact on health. In 2017, the Scientific Advisory Committee on Nutrition and the Committee on Toxicity, they reviewed the evidence on potassium-based salts in particular, and found that there would be health benefits, and they issued a recommendation that the government should encourage the food industry to use these. To date, that recommendation has not been adopted, and it's really not clear why. At Action on Salt, we've been hearing pushback from the food industry that consumers like clean labels. They don't want to see potassium chloride on the label. With everything else that they put into food, I cannot see why potassium chloride would be the tipping point. It feels like a delay and deflect tactic. And I'll also add in here the barriers that Bruce has already covered. There does seem to be some concern within government and health bodies about these negative health impacts, which are unfounded. Price is an issue. I had a look yesterday, and a 350 gram tub of a potassium salt is selling around £2, whereas you can get a 750 gram tub of a sodium salt for 65 pence. And then there's the availability as well. There's not a huge market demand for these products at the moment. And so many retailers like Asda, Tesco, Sainsbury's, they're not yet making their own versions, which would be cheaper than these kind of leading market brands. And then there's so many rock salts, sea salts, Himalayan salts, and then these new tubs of kind of gourmet flavored salts. It's so overwhelming for consumers, and it's really it's clear why those aren't necessarily being bought. But there are opportunities. It will be tough, but there are some ways forward. And I am nothing if not an advocate at heart. And we need advocacy if we're going to make any sort of headway. We do need a united voice. Anyone who could possibly speak out on this, from heart and stroke organisations to healthcare professionals and many more besides, we need to reach them and ask them to join together for a united message to the government and the food industry. Coming back to front of pack labelling, we know that the government is currently reviewing the UK's front of pack labels just to make sure that they're as clear as possible for the public. In our submission to that process, we noted that potassium content is not it's not even noted on the back of pack. It's not usually stated, let alone the front of pack. And so, as a simple way forward, why don't we rework that system and make sure that potassium content is declared, and work in some sort of awareness to say, as a population, we're not eating enough, and that might encourage the use. And building on that, on awareness, one of those kind of early success factors for salt reduction, for so many years, the government has not told the public the dangers of eating salt. We haven't had any kind of public awareness campaigns. We just need some simple messages to tell people to eat less and to highlight potassium salts as a potential way forward. Leaflets in GP surgeries would go a long way, even messages on social media. And that's where we as kind of advocacy groups can join together and present that united message. And just to finish by saying that we do need to think outside of the box of the Department of Health and Social Care and Ministry of Health departments worldwide. We need cross-government approaches to health, to protecting and promoting health in general, not just salt reduction. An example is, recently the National Food Strategy recommended a tax, a reformulation tax on wholesale salt and sugar. They proposed a £6 per kilogram tax on wholesale salt, and that would encourage the food industry to buy less and then put less into their products. And if the Treasury went ahead with this, that could raise the price of salt and bring it more in line with potassium salts. It would be great to then see some sort of subsidy coming in that would help make these lower sodium salts the default choice, much more affordable and available to everyone. And other government departments, like DEFRA and the Department for Business, they have so much interaction with the food industry. The food industry has so much power there. But if the government are serious about protecting health, they should be investigating with the food industry what the barriers are, what the perceived challenges would be, and start to come up with solutions. And our advocacy efforts together, if we join together, can help communicate that need to government. And I'll end there, but it's been lovely to speak to you about this, and I'm looking forward to the discussion.
Mhairi, thank you. That felt a bit depressing. So maybe among the people listening, we can hear some ideas, some enthusiasm for what we can do. I think it's depressing for real. I'm not criticizing at all. So one of my questions, perhaps to both of you, but maybe to start with Bruce, is Mhairi's presentation particularly was sort of very honest and open about working with the public, and there's part of me wonders whether we wouldn't do better by some form of stealth. That taste and how it changes is something the food industry definitely knows about, because that's how they persuade us into most of the bad things. What's the balance, if you like? Is it both between public campaigning and advocacy? And there's something about the word potassium, I think, that's not terribly familiar for people, to a more stealthy approach, which of course would require the food industry to be signed up, I guess. So what's the balance? And is it about what's likely to happen, or is it about what works best? So Bruce, over to you first.
Yeah. So, I mean, good question. So I think, in terms of sodium reduction in a country like the UK, where most of the salt comes from processed and packaged foods, the ideal solution would be for every company to put 5% less sodium into every product each year, do that for 5 years. And we've done work in the past which has showed that if you take 5% of salt out of breads a week, over a 6-week period, and give those progressively lower sodium breads to people, people don't notice the difference. If you just give them the same bread and then drop it by 25% on the 6th week, they all throw their hands up in the air and go, oh, this tastes really different, I don't want it. So I think that would be ideal. But the trouble is with the food industry, it's just not a tractable problem, because there are tens and tens of thousands of companies just in the UK making these sorts of products. So that would only work if you had if you had a really strong government regulation that basically said you have to do this, and an enforcement strategy. Now, you're quite right. Low salt is widely perceived in a negative way as low taste by community, and it's not something that industry have been able to advertise on. I think there is potentially a difference with potassium enriched salts, because we are looking at the moment of what is the current form of labeling in terms of benefits and risks on potassium enriched salts all around the world, with a view to trying to put forward a standard form of labeling which actually says, if you use this salt instead of regular salt, you are going to potentially have benefits for your blood pressure, and also potentially benefits for the risks of stroke, heart attack, and dying prematurely. And there are many countries in the world which now allow health claims on products. And I think that if we were able to formulate a suitable health claim for a potassium enriched salt, there might be an opportunity for us to do that, and to promote uptake in a non-stealth way.
Thank you. Glenn has his hand up. So Glenn, please ask your question or make your comment, and others, please put your questions and comments in the chat. Glenn, over to you.
Yeah, thanks very much for that. I found that really interesting, and I'm trying to think about how we could introduce like potassium salt into care homes. So I may have to say I'll need to go through your study because I don't really, I haven't got my head around all the details yet. But what I was wondering is what, you're saying about the relative risk reduction. What's the absolute risk reduction? Have you got any idea of that?
Yeah, so first of all, on care homes, we did a study in China, which we published in Nature Medicine just a couple of weeks ago, which actually randomly assigned about 45 care homes to use potassium enriched salt in the kit. I mean, in China, the kitchens make most of the food for the care homes, so we just switched the supply, and we saw pretty substantive blood pressure reduction, similar to what you get from giving everyone a drug therapy. So it was definitely an option there. Probably the setup in the UK is a bit different. In terms of the absolute effects, I mean, in the study that we did in China, they were pretty high because we selected a population that wasn't very high risk. So there were people who were like, they'd had prior stroke, or they had high blood pressure levels. The absolute risk population wide will obviously be much smaller in younger people, because they're very unlikely to get strokes or heart attacks, even if they had high blood pressure. The other part that I didn't really talk about is that if you use a potassium enriched salt, or if you eat less sodium, what you also do is you reduce your risk of getting hypertension. Hypertension is probably still in the UK the single most common reason why people go to see their GP, and a huge drain on resources. So there's lots of potential benefits beyond just the preventing strokes and heart attacks from a sort of health economic and sort of resource usage perspective as well.
Yes, actually, just to put my point, tuppence worth in about what you're just saying, we've done the same with folic acid, so I don't see why we couldn't do it with salt. Right. Yeah,
I was going to make that comment because the folic acid study and the issues were triggered in my mind by Bruce's chat. So Bruce is obviously ready to respond to that. Then you can keep your hand down.
Oh, sorry.
Right. Bruce.
Oh, look, I mean, yep, there are. I mean, again, folic acid is another nice example of where a food fortification program has been implemented with significant success. One thing I didn't say about the iodization program is that the iodization program started in 1920 and took about 80 years to get any traction, and it's only in the last 20 years that it's really been rolled out. So we do want to try and do a bit better with potassium enriched salt.
So Katie Cooper, who probably heard your first presentation. Katie, do you want to raise your question?
Sure. It's a two-part question. This may be well, one probably for Bruce and the other one for Mhairi. Are we the best of a bad lot still? It sounds from the WHO report like very few countries are making progress on this. So is the progress we've made still actually world leading, even though there's a long way to go? And the other question is when do we find out just how well we're doing? 2017 feels like a long time ago. For the latest sort of 2018, I think, stats on intake. So I was wondering if OHID has any update planned. So two-part question.
Okay, Bruce, you can take.
I think Mhairi can probably answer these better than me. She's all over the UK stuff. Thanks.
Okay, Mhairi, over to you.
Thanks. Yeah, it's a great question. Yeah, so we do still have one of the most established salt reduction programs in the world, but we are still heavily reliant on those voluntary measures. The days of impactful voluntary measures are probably far behind us now. Around 19 countries now have legislated targets in place. For many countries, they've legislated targets to lower salt levels in bread, because that's the main source of salt in their diets. But there are some great examples like South Africa and Argentina that have legislated targets across several key contributors of salt to diet. South Africa studies are kind of still emerging from there, but we do have some initial evidence that shows that the targets were implemented in 2016, and since then there's been about a 1 gram drop in population salt intake, quite a large drop to see in such a few years. And really great to see that there have been larger falls in salt intake in those from lower socioeconomic groups. They are more likely to eat more salt, so having a real positive benefit. And then yes, updates from OHID. So we were due.
You might need to spell it out, Mhairi, for
Yes,
it's
the
hard
office
for the
for
English to know what the heck we're talking about. I can't manage it most times, so.
Yes, the Office for Health Improvement and Disparities, which they were set up to replace Public Health England, and they sit within the Department of Health. They were due to release a monitoring report on the food industry on their progress towards the salt targets. That was due last year. We've heard that it's now delayed until next year when the targets are due to be met, so not really serving a whole lot of purpose. And there was a commitment back in 2019 to release a new update on salt intake in the UK. I think it was due this year. To my knowledge, that hasn't happened.
I think you'd know if it had, so yeah.
Yeah, we would know if it happened. Yeah, so delays all around.
So we've
Thank
two
you.
people waiting. Thank you, Mhairi. Two people waiting to ask questions. So Ada from Malaysia first, and then followed by Andy Jones. Ada, which I may have pronounced your name wrong, but I hope not. Please ask your question. You need to unmute yourself if you can. So maybe maybe I'll read, because most people being able to see, I think. It's really a comment on whether the food industry will change. And is there anything cheaper that might encourage the food industry to change? Bruce, your comments on that?
Yeah, so I mean, there are definitely pieces of the food industry that are, I think are genuinely keen to do the right thing. I think that the key challenge is that, if you're a company that produces a breakfast cereal which has sodium in it, they often have quite high levels of sodium, and then you produce a breakfast cereal which is sort of similar to something that's produced by other competitors, you take a bunch of the sodium out, it tastes different, and then the next time someone happens to buy your competitors, they go, oh, actually, I think I prefer this one now. So I think, there's a huge challenge for the food industry in that it only really works if everyone does it. And everyone will only do it if government requires it. And that's why, I mean, to Mhairi's point, the regulated interventions are so important, because they actually provide for a level playing field within which industry can operate. And I've had several industry players in the past say to me, oh, actually, we'd really like industry, if this is going to work, we need industry we need government to regulate. And actually, we'd quite like that, but don't tell anyone else that, because regulation is sort of generally anathema to the food industry. So as a food industry player, you would be, frowned upon if you were to go and say, yeah, can we have more regulation, please? So I'm not super hopeful that the food industry will voluntarily achieve a great deal in this space. I mean, in Australia, I spent 20 years working in sort of with the food industry in partnership with government, and frankly achieved nothing. And from my perspective, I'm not going to spend a moment of my time working on anything but potassium enriched salts moving forward in terms of sodium reduction, because I just feel like there's an opportunity here which I just haven't seen with anything else. And please don't everyone else stop doing anything in that space. But personally, that's how I'm feeling after a very long time.
Yeah. So moving in a way to challenges about where do we put our energy and our effort. Andy Jones, can you ask your question? Because I think that moves in that direction very well.
Yes. I mean, thanks to both of you. It's great presentations. I mean, I was interested. I mean, as is often the case with dietary interventions, you've always got that interplay between the effect of reformulation on its own and any behaviour change. And I guess my sort of specific question was originally around Bruce's SAS trial, but I think maybe Mhairi might like to chip in as well. And I was interested in whether there was any evidence of behaviour change, particularly in that trial, given that the two groups were not blinded. So whether there was a reduction in intake even amongst the intervention and potassium-rich group, and then perhaps for Mhairi, what this implies around messaging, because sitting here as a sort of middle-class educated public health person, I'm thinking I need to stop using any sort of sodium, whether it's potassium enriched or not, and go onto the Solgar website and buy some potassium supplement tablets. Now that's obviously a complex message though, so where do we need to go in that direction?
Wow, great. So Bruce first and then Mhairi, or the other way around? Dive in.
Yeah. So I'll pick up quick response to that. So it's a really good question, and we spent quite a lot of time trying to figure out what did they actually eat, and the complexity is there because you're never quite sure how much of the sodium comes out in the urine, particularly when you supplement potassium. That actually modifies how much of the sodium you eat that comes out in the urine. And the main way we try to work this out is by looking at urinary sodium and potassium levels, because it's just too hard to actually measure what people put in their food and the like. The bottom line is that we think that on average, people probably over-replaced the salt that they stopped eating with the potassium enriched salt a little, but only marginally so. And it's possible that they, and the people who were in the potassium enriched salt replaced about 2/3 to 3/4 of all of their regular salt with the potassium enriched salt. And we went a step further to say how much of the blood pressure reduction and the protection that we saw in the SAS study was actually attributable to the sodium reduction versus the potassium supplementation. And we think at least half of it was attributable to the potassium supplementation, and up to 2/3 of the benefit in this setting was probably attributable to potassium supplementation. And that's because in China, potassium intake is really low in the settings that we were working. I'll hand over to Mhairi to address the.
Thanks.
Thanks. Yeah, great question. I think from the UK, we have had the benefit of having a public awareness campaign and the reformulation program. And while the public awareness campaign was a great kind of short-term measure, it really just supported the implementation of the salt reduction program. Evaluations of that have shown that people, awareness increased, and those that were much more health conscious did start to reduce the level of salt that they were adding into their food. But it's really only reformulation, I think, that could make a difference within this case. We can raise awareness, but if salt is in everything that we're buying, it's really difficult for consumers to see that and access that. So the public awareness campaigns can kind of just encourage you to use less, to check front of pack labels, and to choose a potassium salt instead. But it's the reformulation program, that kind of government guided upstream intervention that's going to have the real impact.
So we've hardly a minute left, but Bruce and Mhairi, how about a sort of one-word recommendation to the people participating? Is where should we put our effort? Should it be on lobbying the food industry? Should it be on trying to get government? Where should we put our effort, having listened to inspirational and real evidence of what's so important? Bruce and then Mhairi.
Can't do it in one word, but I think that the couple of things where I think there's real opportunity, I think working to raise awareness with clinicians, because we can we can get across to them the balance of risks and benefits, and they have pretty much nothing practical they can do when they say go away and eat less sodium. I think this is a really practical thing that they could do. The other thing that I'm really interested in is having some discussions with one of the big retailers in Australia at the moment about trying to get an own brand potassium enriched salt on the shelves at an affordable price. I think that also could play a really big part in raising awareness and getting it going in Australia.
Thank you. And on your first point, one of the things that C3 is doing quite a lot of is working with nurses. We're doing some programs globally on oral health at the moment. And of course, with 28 million nurses in the world, if they could hear that message, and you've got some advocates that may not be powerful, but they'd be influential locally. Mhairi, you're, I think, going to have the last word. So over to you.
Yeah, I fully echo that point around healthcare professionals. They are the trusted messengers in communities, and a really, a really useful resource. But yeah, if you have capacity, please write to your MP. Anybody talking about salt is going to be really useful. The MPs do not hear enough about salt reduction, so please do contact them.
Thank you. And thank you both very much for raising what's almost an old problem, a big problem, but with wonderful evidence and messages that I think hopefully will energize many of the people who've joined today, and we've had a large number join. Thank you to the George Institute for joining us, for making the introductions, and for bringing many people into this seminar. And please, if you haven't already, signed up to C3's network, and make sure you hear about our June seminar, which we think will probably be coming from Mexico, so you won't have to get up quite so early to listen to it, and all news by following on our website. Thank you, Bruce. Thank you, Mhairi, very much indeed for such a great session. And thank you all for participating. Thanks. Goodbye.